examination. Any patient coming to you with burning sensation or increased frequency of micturition or any of these urinary complaints, the first investigation that you do is urine microscopic examination. अब ये बताओ, in normal urine, which type of casts can be seen? Shabash. In normal urine, which type of casts are seen? Iodine cast. In normal urine, which type of casts are seen? Iodine cast. WBC casts are suggestive of infection, that is pyelonephritis. WBC casts are seen in pyelonephritis में कौन से casts दिखेंगे? RBC casts are suggestive of hematuria. RBC casts are suggestive of hematuria. Hematuria is a feature of glomerulonephritis. So RBC casts are seen in RBC casts are seen in glomerulonephritis में किस टाइप के casts दिखेंगे? RBC casts. Then lipid casts are seen in fatty casts or lipid casts. Sometimes they can even mention oval fat globules in urine. Steatorrhea is fat in stool. I am asking about urine examination. Oval fat globules in urine, lipid casts or waxy fatty casts. Lipiduria किसमें होता है? Nephrotic syndrome. So lipid casts or fatty casts are a feature of nephrotic syndrome में किस टाइप के casts? Lipid और fatty casts. Whereas waxy casts are seen in chronic renal failure. Waxy casts are seen in chronic renal failure. ठीक है, no issues with this. ठीक है. Now moving to next one. अगर हमें urine microscopy पे we are finding some type of crystals, right? What are they likely suggestive of? They are likely suggestive of some kind of renal stones, right? They are likely suggestive of some kind of. They are likely suggestive of mostly renal stones. The first topic that we will discuss is actually renal stone or nephrolithiasis. It is important from surgery point of view as well. So, अच्छे से देखना. Can anybody tell me what is the investigation of choice for renal stone? Investigation of choice for renal stone. अब ये बताओ जरा, renal stones are radio opaque or radiolucent? Mainly they are made up of most common type of renal stones are calcium oxalate stones. Calcium stones can be radio opaque or radiolucent. Radio opaque, they will appear white on X-ray or CT. So ultrasound पे तो वो दिखेंगे ही नहीं. Ultrasound क्यों करना है? Ultrasound is never an investigation in cases of renal stones. Investigation of choice for renal stones is NCCT abdomen. Investigation of choice for renal stones is investigation of choice for renal stones is NCCT abdomen. First line investigation would be X-ray KUB. First line investigation is but investigation of choice NCCT abdomen. No issues with this. Now we will also send a urine microscopic examination, and on urine microscopic examination, if I am finding these kind of crystals, what are these? Which shape? These are envelope shaped crystals. These are suggestive of envelope shaped crystals are seen in calcium oxalate stones. They are seen in calcium, which are the most common type of renal stones. The most common type of renal stones are previous year question. Okay, so calcium oxalate stones can have dihydrate crystals or monohydrate crystals. Dihydrate crystals would be which shape? Dihydrate crystals are envelope shape. Dihydrate crystals are whereas monohydrate crystals are right. What you can see over here, dumbbell shaped crystals. So monohydrate calcium oxalate crystals are okay, no issues. Most common type of renal stone. Now please tell me, calcium oxalate stones are mostly found in which type of pH? These are the only pH insensitive renal stones. That means they can be found in alkaline as well as acidic pH. So pH insensitive renal stones are calcium oxalate stones. Next, if I see these kind of crystals on urine microscopy, what are these? क्रिस्टल्स का शेप क्या है? So coffin lid shaped crystals. Coffin lid shaped crystals are a feature of true white stones, also called as triple phosphate stone. True white stones also called as triple phosphate. So coffin lid shaped crystals are seen in triple phosphate stone में कौन से shape के crystal? Coffin lid shaped crystals. These triple phosphate stones usually they have the tendency, they can take the shape of the pelvic axial system of the kidney. ठीक है, they can be so large and therefore these are called as true white stones or which type of calculi? Staghorn calculi. So triple phosphate stones are also called as true white stones or Staghorn calculi or true white stones. Triple phosphate stones are formed in which kind of pH? These are formed in alkaline pH. Please remember, true white stones are formed in alkaline pH. True white stones are formed in, and the patient will give a history of urinary tract infection. And which organism is seen? Proteus. So this is an important keyword in the question. If the patient is having a urinary tract infection with organism known as Proteus mirabilis, there will be a high tendency to form which type of renal stone? So Proteus is associated with triple phosphate is associated with this which type of infection and which type of pH? No issues with this. Proteus causes alkaline pH, therefore high risk of triple phosphate stone. Next, if I see these hexagonal shaped crystals, these are suggestive of cystine stones. Hexagonal shaped crystals are suggestive of and what is the important feature of cystine stone? They are the hardest renal stones. So hardest renal stones are then if I see irregular shaped crystals on urine examination, right? Irregular shaped crystals on urine examination, it is usually suggestive of uric acid crystal or urate crystal. ठीक है? Irregular shaped crystals are feature of irregular shape, and uric acid stones would be formed in which condition? Chronic gout. Hyperuricemia कहाँ होता है? Gout में. So uric acid stones would be formed in. And what is the most common pathology behind calcium oxalate stones? Anybody? This was asked. Hyperthyroidism से भी ज़्यादा common है idiopathic hypercalciuria. Okay, most common cause of calcium oxalate stones is idiopathic hypercalciuria. Important. ठीक है, no issues with this. So now talking about renal stones, कौन से रेडियो ओपेक होते हैं और कौन से रेडियोल्यूसेंट? Radiolucent means they cannot be visualized on an X-ray or a CT scan. These are called as radiolucent stones, and these are remembered by the mnemonic PG love. So radiolucent stones are remembered by PG love. So P for parotid stones, P for parotid or salivary gland stones, G for gallstones, G for, and as they are radiolucent, so therefore they are not visualized on X-ray or CT. The investigation of choice for gallstones is ultrasound. Investigation of choice for gallstones is abhi yaad rakhe. L for lysine stones, U for uric acid stones, U for, and X for xanthine stones, X for xanthine stones. No issues with this. So jaldi se batao. pH insensitive stones are calcium oxalate. Alkaline pH में triple phosphate. Acidic pH में uric acid और sometimes xanthine stones as well. ठीक है? Radiolucent stones, PG, P for, G for, L for, U for, X for. Investigation of choice for gallstones. Now, if a patient of chronic gout comes to you, ठीक है, and you perform a joint aspiration. On joint aspiration क्या check करते हो? Synovial fluid. So synovial fluid microscopy पे, if I get these type of crystals, what are these? Needle shaped crystals. Which shaped crystals? Needle shaped crystals मिलेंगे मुझे. And when I see them under polarized microscopy, they will be positively birefringent or negatively birefringent. They are negatively birefringent. These crystals are negatively birefringent. Please remember. And these are usually which type of crystals? These are monosodium urate crystals. These are okay, and these are seen in cases of gout. These are seen in cases of gout. Whereas if a patient again with joint inflammation comes to me, I perform a joint aspiration, and on synovial fluid examination, I can see these rhomboid shaped crystals. I will see these rhomboid shaped crystals. These are positively or negatively birefringent. These are positively birefringent. Okay, and these are which type of crystals? These are made up of calcium pyrophosphate crystals. These are calcium pyrophosphate crystals, and they are seen in cases of pseudo-gout. They are a feature of. Okay, समझे? So please remember, if a patient comes to you with joint inflammation, maybe your first metatarsopharyngeal joint inflammation, I will perform a joint aspiration and I will send the synovial fluid for examination. On microscopy, if I see needle-shaped crystals, it is likely suggest your these needle-shaped crystals and gout would be negatively birefringent. And they are which type of crystals? Monosodium urate crystals. Next, again the same case scenario, but here on microscopy I get the shape of crystal, Glomerulonephritis crystals. The on polarized microscopy would be positively birefringent. These are made up of DPKD, that is calcium pyrophosphate, and these are seen in cases of pseudo-gout. Pseudo-gout में कौन से crystals? Pseudo-gout में कौन से crystals? Gout में कौन से crystals? Gout में कौन से crystals? Negatively birefringent है, positively birefringent है, needle shaped है, rhomboid shaped है. No issues with this. Done. चलो आगे बढ़ते हैं. Now talking about the important condition, and पहले तो एक सर्जरी से भी पॉइंट डिस्कस कर लेते हैं. Treatment for renal stone. If a renal stone is less than 2 cm, what is the surgical management? ESWL, extracorporeal shock wave leukotomy. Stone less than 2 cm क्या करोगे? ESWL. And if the stone is more than 4 cm, 2 cm, PCNS. Stone more than 2 cm, PCNS. It is percutaneous nephrolithotomy. More than 2 cm, percutaneous nephrolithotomy. We will discuss this surgery. Don't worry about that. ठीक है? Moving further. Differences between nephrotic syndrome and nephritic syndrome now. ठीक है? I hope you are quite aware both of these are glomerular diseases. There would be glomerular damage in these conditions. So how to differentiate whether it is nephrotic or nephritic? For nephrotic, the essential features or the essential criteria. First, most important criteria is proteinuria. First is important is so proteinuria is seen in both nephrotic as well as nephritic. In nephrotic, it is more than 3.5 grams per day. In nephrotic, it is whereas in nephritic, it is okay. So massive range on nephrotic range proteinuria more than 3.5 grams per day is a feature of nephrotic syndrome. Okay. Next, the feature now there will be loss of protein, and mainly there is loss of which protein? Albumin. Mainly loss of albumin. So therefore there would be hypoalbuminemia. Therefore there would be hypoalbuminemia. And like albumins are responsible for which type of pressure? Plasma oncotic pressure. Albumin is responsible for. So if albumin is low, plasma oncotic pressure would be low, and the water or the fluid would be pushed out of the blood vessels, and that would lead to the third important feature, that is edema. So edema is usually seen in cases of nephrotic syndrome, right? It can be generalized edema, which is called as generalized पूरी body सूजी हुई होगी. Generalized edema is called as anasarca. In question they will mention anasarca. Don't get confused. Generalized edema is called as and it is a feature of nephrotic syndrome. ठीक है? Next feature, guys, please remember in cases of nephrotic syndrome I'll discuss. These were the 3 essential features. इसके अलावा the patient will also have hyperlipidemia. There would be hyperlipidemia, and excess of lipids would also be excreted out in urine. That will cause lipiduria. And lipiduria की वजह से which type of cast was seen? Fatty cast. Which type of cast was seen? Fatty cast in urine. And last one. Now proteins are lost. So protein C, protein S, antithrombin free. All these proteins would also be lost. These are anti-clotting system or the anti-clotting proteins. So if anti-clotting system is lost, the patient will have a hypercoagulable state. The patient will have hypercoagulable state. Okay, important. Next, if I talk about nephritic syndrome, guys, please remember, apart from a nephritic range proteinuria less than 3.5 grams per day, the patient will also suffer from hypertension. And the third and the most important feature to differentiate is hematuria. Hematuria means presence of RBCs in the urine. How many? More than 3 to 5, you can say, more than 3 RBCs per high power field of microscope is considered hematuria. Okay? So if hematuria hai, you will call it nephritic syndrome. Hematuria hai to, edema hai to, hypertension hai to, hypoalbuminemia hai to, proteinuria more than 3.5 grams, proteinuria less than 3.5 grams. No issues with this. Done. So यही important features से याद रखना. Next, if I talk about the first example now. पहले एक या और एक feature बता देता हूँ. Nephrotic syndrome from pathology. As we are covering other parts also, so we will also cover pathology aspect. Nephrotic syndrome में, please remember, it is also called as proliferative or membranous glomerulonephritis. Non-proliferative or membranous glomerulonephritis. याद रखना, non-proliferative or membranous glomerulonephritis. Whereas nephritic syndrome is called as proliferative glomerulonephritis because there will be proliferation of cells seen on the biopsy. Okay? Moving further. First question says, a child is brought to you with complaints of cola-colored urine. Sarkari question is repeated multiple times in exam. Cola-colored urine is a feature of hematuria. That means the child is suffering from hematuria. And he gives history of skin infection 2 weeks ago as given below. What is the skin infection called as? Honey-colored crust. It is a feature of impetigo. This was a previous question which has been repeated multiple times. Honey-colored crust in a child is suggestive of impetigo. Important from Dharma also. Okay? Now please remember, if a child is having a history of impetigo or any skin infection, sometimes they can even mention pharyngitis or sore throat in the patient. And the organism which is isolated is group A beta hemolytic streptococcal. The organism responsible would be group A beta hemolytic streptococcal, also called as Streptococcus pyogenes. So Streptococcus pyogenes is responsible for the skin infection known as impetigo. It can lead to pharyngitis or sore throat in a patient, and following that, in a period of 2 to 3 weeks, the child will present to you with complaints of hematuria. So if hematuria is present, it is nephrotic or nephritic? Nephritic syndrome. And nephritic syndrome in a child after 2 to 3 weeks of a skin infection or pharyngitis, the diagnosis in this condition is PSGN, post-streptococcal glomerulonephritis. Okay. And please remember, post-streptococcal glomerulonephritis is the most common cause of nephritic syndrome in children. The most common cause of nephritic syndrome in children is most common cause of nephritic syndrome in children is most common cause of nephritic syndrome in adults is IgA. ठीक है, तो PSGN समझ गए क्या होगा? There would be a history of skin infection like impetigo or pharyngitis with which organism? Group A beta hemolytic streptococcal. And following 2 to 3 weeks after, the child will present to you with complaints of hematuria or cola-colored urine. Sore throat या pharyngitis की history होगी. Now the child presents to you with hematuria. Now the child presents to you with the diagnosis of PSGN. If I talk about pathological aspects of PSGN, if I take a kidney biopsy, though kidney biopsy is not recommended for diagnosis, if I take a kidney biopsy, what would we see? Is it mesangial or endocapillary? So we can find endocapillary proliferation. As it is a proliferative glomerulonephritis, so I would find endocapillary proliferation. I'll find endocapillary. So endocapillary proliferation is seen in PSGN. And if I look at the immunofluorescence picture, on immunofluorescence, which type of appearance is seen, right? This looks like a starry sky appearance. This looks like a starry sky appearance, right? Also called as lumpy bumpy appearance. Also called as so lumpy bumpy appearance on immunofluorescence is a feature of starry sky appearance on immunofluorescence is a feature of starry sky appearance on ultrasound abdomen is a feature of jaldi se haath uthao. Starry sky appearance ultrasound abdomen. Raise your hand. Ultrasound abdomen. Acute viral hepatitis. Okay, please remember, starry sky appearance on ultrasound abdomen is seen in. Starry sky appearance on ultrasound abdomen is seen in. Starry sky appearance on NCCT head. Urocystic sarcoma. Starry sky appearance on NCCT head. And starry sky appearance on kidney biopsy. Last question and most important. Starry sky appearance on lymph node biopsy. Starry sky appearance on lymph node biopsy. Some starry sky yaad ho gaye. Important, please remember. Next, please remember this same organism, guys. The organism which causes PSGN or IgA nephropathy, pharyngitis, or impetigo, group A beta hemolytic streptococcal, strep pyogenes, is also known to cause a exanthematous fever, where the child will have strawberry tongue and these erythematous maculopapular rashes would be seen. This condition is, मैंने क्या बोला? Did I say vasculitis? I said exanthematous fever. Important. And in Kawasaki disease, please remember, usually in Kawasaki disease, infection is not the cause. It is an autoimmune condition. Please remember. So if it is an infection which is causing exanthematous fever in a child along with erythematous maculopapular rash, and which type of a tongue? It is a feature of so strawberry tongue is seen in two conditions. First is Kawasaki disease. Second is no issues with this. Important. Scarlet fever is also caused by the same organism. Okay, no issues. Pediatric question important. Now please remember PSGN में treatment क्या लोगे? What is the treatment? Right, it is infection. So the treatment would be antibiotics. Which antibiotic? Benzathine, penicillin. So drug of choice for PSGN is benzathine, penicillin. No issues with PSGN now. Done. Very good. Moving further, talking about the next condition. Same history. A patient, okay, a 30-year-old male had a previous history of recurrent sore throat. Now, after 2 to 3 days of the infection, the patient presents to you with hematuria. What is the cause? The diagnosis in this condition would be IgA nephropathy. IgA nephropathy is also called as Berger's disease. And Berger's किसको बोलते हो? Thromboangiitis obliterans. It is a type of vasculitis. We'll discuss it. Okay? So if they ask you most common cause of nephritic syndrome in adults, answer is most common cause of nephritic syndrome in adults. Answer is most common cause of glomerulonephritis. I have not mentioned nephrotic. I have not mentioned nephritis. Most common cause of glomerulonephritis. Again, IgA nephropathy. Most common cause of glomerulonephritis worldwide is IgA nephropathy is also called as. And the patient will have a history of sore throat or skin infection. And post how many days the patient will present to you with hematuria? So 2 to 3 days के बाद hematuria, 2 to 3 weeks के बाद hematuria, child में, adult में, एक और adult जैसे याद रखो, ठीक है? If I look at the light microscopic finding of the kidney biopsy, what I will be able to find? There would be mesangial proliferation. What I will be able to find? So mesangial proliferation is a feature of Mesangial proliferation is a feature of. And on immunofluorescence, what I'll be able to see? There would be deposits. Which type of immune deposits? So please remember in PSGN, which type of immune deposits are seen? You can find IgG and C3 deposits. They are usually subepithelial or subendothelial. So subepithelial or subendothelial deposits of IgG and C3, they actually lead to this starry sky or lumpy bumpy appearance of PSGN. But in cases of IgA nephropathy, by the name it is evident. Here also we will find deposits, but it would be IgA and C3 deposits. Okay, here I will find which type of deposit? Where I will find them? Subepithelial, subendothelial, mesangial. Mesangial deposits. Okay, please remember. So mesangial deposits is a feature of. Mesangial deposits is a feature of. Which type of deposits are seen in cases of IgA? Which type of deposits are seen in cases of IgA? Which type of deposits are seen in cases of PSGN? Okay, now please tell me, they would be granular or linear? In both the cases, they would be granular. In both the cases, they would be. So I will give you two punchlines. They flow very flow. Okay, might have given. All glomerular diseases have granular deposits except for good Marshall syndrome, where we will find linear deposits. All glomerular diseases have IgG and C3 deposits except for IgA nephropathy, where we will find IgA and C3 deposits. No issue with this? Okay? Moving further, guys, now. IgA nephropathy में क्या treatment दोगे? So for proteinuria, you can give steroids to the patient, but again, antibiotics are usually preferred in this patients as well. Okay, no issues with this. What is the CD marker for IgA nephropathy? Anybody? It is CD. CD marker of IgA nephropathy. CD marker of IgA nephropathy. CD71. No issues with this. Done. Moving further. Now a child presents to you with complaints of क्या होता है triad? Can't see, can't pee, can't hear. And what is this suggest you of? This is suggest you of the most common cause of hereditary nephritis. Most common cause of hereditary nephritis is? Most common cause of hereditary nephritis is? Most common cause of hereditary nephritis is? Alport syndrome, right? And Alport syndrome causes nephrotic or nephritic syndrome. It causes nephritic syndrome. Okay, so the patient can't see because he has an ocular manifestation, which is called as the patient has anterior. The patient has anterior. So ocular manifestation in Alport is known as ocular manifestation in Alport is known as ocular manifestation in Alport is known as. This question has been asked. Important. ठीक है, ये image दी हुई थी and a classical case of Alport syndrome with a child presenting to you with hematuria was given. ठीक है. Now, if I perform a kidney biopsy of this patient on light microscopy, I would not find many things. But on electron microscopy, I'll see a characteristic appearance, and that is due to thinning and splitting of the basement membrane. And this is called as the basket view appearance. So, which appearance is seen in Alport? Which appearance is seen in Alport? Which appearance on electron microscopy in Alport? Basket view appearance. Okay. So, as the kidney or the glomerular basement membrane is damaged, therefore the patient will present to you with complaints of hematuria. This explains the can't see component. And can't hear because the child will suffer from sensory neural hearing loss. Okay, no issue. So, एक बार revise करते हैं triad of Alport syndrome. Can't see means there would be. Can't be means there would be. Can't hear means there would be. Sensory neural hearing loss in the child. Most common cause of hereditary nephritis is electron microscopy shows which appearance? Basket view appearance. Now please tell me, as it is a genetic condition, definitely there would be some gene mutation. This gene mutation is seen in alpha 5 chain or alpha 3 chain? Alpha 5 chain. Of which type of collagen? Of collagen 4. So gene mutation is seen in alpha 5 chain of collagen. Alpha 5 chain of collagen collagen 4? Which chain of collagen 4? Which chain of collagen 4? Alpha side chain of which collagen? And collagen 4 is present है? Collagen 4 is present है? This was the question. One liner is straight away. Collagen 4 is present है? Collagen 4 is present है? Collagen 4 is present है? As there is a defect in this collagen 4, therefore there would be thinning and splitting of the basement membrane, which gives which appearance? Done? No issues? Now, last question for Alport syndrome, last two. The most common and the earliest manifestation in Alport. Out of these three, the most common and the earliest manifestation in Alport. Most common, वो nephritic में पढ़ाया जा रहा है, एक reason तो होगा. So most common and earliest manifestation is most common extra renal manifestation apart from kidney. Then it is sensorineural hearing loss. Most common extra renal manifestation is and most common earliest manifestation is done with Alport. No issue. Ocular finding को क्या बोलता है? Anterior lenticulus. Moving further, here the patient will only receive symptomatic management because genetic defect है. ठीक है? Next, now I perform a kidney biopsy of a patient, okay, and I find this kind of appearance in the glomerulus. ठीक है? So this part of the glomerulus is actually affected, and it is which shape? This is half moon shape or crescent shape. So crescents are found in the glomerulus. So crescents are found in the glomerulus. It is suggestive of crescentric glomerulonephritis. In pathological terms, we call it crescentric glomerulonephritis. And crescentric glomerulonephritis is found in RPGN. Crescentric glomerulonephritis is found in that is rapidly progressive glomerulonephritis. And RPGN has the worst prognosis. RPGN has the okay, and what is seen on kidney biopsy? Crescents are seen. What is seen on kidney biopsy of RPGN? Crescents are seen. No issues with this. Now RPGN can be of three types, guys. RPGN type 1, RPGN type 2 and RPGN type 3. Images याद नहीं रहती, मैं बस दिखाने के लिए बता रहा हूँ. It would be easy to understand. RPGN type 1 is actually antibody mediated. And RPGN type 1 is usually, so which type of antibodies are formed? And which type of antibody? Anti-glomerular basement membrane antibodies, anti-GBM antibodies. Which type of antibodies are seen in type 1 RPGN? Which type of antibodies are seen in type 1 RPGN? So as it is antibody mediated, so which type of hypersensitivity? As it is antibody mediated, so which type of hypersensitivity? Type 2 hypersensitivity. Whereas in cases of IgA nephropathy or PSGN, here there was deposition of immune complexes. So due to deposition of immune complexes, that means it is which type of hypersensitivity? So it is type 3 hypersensitivity. No issues with this. PSGN and IgA are nephropathy are type 3 hypersensitivity. Whereas type 1 RPGN, that is good partial syndrome, if in option you have type 2 and type 5, which will mark? You will mark type 5. Okay? It is a subtype of type 2, but it is more specific for good partial. Okay? So if you have both type 2 and type 5, you will mark type 5 followed by type 2. Okay? If you don't have, then definitely you need to mark type 2 as well. So type 1 RPGN is antibody mediated. So which type of hypersensitivity? Which type of antibodies are seen? Anti-GBM antibodies. And the diagnosis is known as good partial syndrome. The two organs affected in good partial syndrome are lungs and kidney. In lungs there would be hemoptysis. Lungs there would be kidneys mein hematuria. So if hematuria is present, so RPGN is a type of nephritic syndrome. No issues with this. Important. गुड पार्शियस में कौन से दो ऑर्गन्स अफेक्टेड है? लंग्स एंड किडनी. ठीक है. Next, if I talk about type 2 RPGN, guys, it is usually associated. It is actually immune complex mediated. So if it is immune complex mediated, it will be which type of hypersensitivity? It is type 3 hypersensitivity. Type 2 RPGN is? Type 2 RPGN is? Hypersensitivity to strong. Type 2 RPGN is? Type 2 RPGN is? Type 3 hypersensitivity. Important, yaad rakh lena, theek hai? And it is usually associated with lupus nephritis, which is seen in patients of SLE, IgA nephropathy, PSGN, okay, subacute bacterial endocarditis, that is SABA. In all these conditions, we will find type 2 RPGN, that is immune complex mediated, and therefore which type of hypersensitivity? Type 3 hypersensitivity. Now, talking about type 3 RPGN. Type 3 RPGN, can you find any deposit? No. So in type 3 RPGN, no deposits are found. Important, in type 3 RPGN, we can find no deposits, and it is therefore called as quasi-immune vasculitis. Therefore, it is called as quasi-immune vasculitis. So it is associated with renal vessel vasculitis, and here we can find vaginal granulomatosis, microscopic polyangiitis, or Church-Ross syndrome. ठीक है, no issues with this. तो जल्दी से बताओ अभी, पहले डिपॉजिट्स लिख देता हूं मैं. Type 1 RPGN या good pastures में which type of deposit was seen? You can see this IgG and C3 deposits. Okay, you can see this IgG deposit that is along the basement membrane. These are along the basement membrane. So which kind of deposit? So IgG deposits in the good pasture syndrome are linear. IgG deposit in good pasture syndrome are linear. All other glomerular diseases we have granular, except for that good pastures we have, and therefore they are also termed as ribbon-like deposits. These are also called as ribbon-like deposits. No issues with this. Moving further, type 2 RPGN, which type of deposits are seen? These are IgG deposits again, but this time these are granular. These are granular. ठीक है, ये समझ गए? Now, a patient comes to you with complaints of hematuria. On kidney biopsy, right microscopy, you can find recess. Diagnosis is confirmed, that is RPGN. Now you need to differentiate out of these things. Immunofluorescence showing linear IgG deposits. Good pasture syndrome. Immunofluorescence showing granular IgG deposits. Type 2 RPGN. Important. And linear immunofluorescence showing no deposit. समझ गया? पहले you will perform light microscopy and then you will perform immunofluorescence. जल्दी से फिर से good pasture में which type of deposit? Immune complex में? Quasi-immune में? Quasi-immune is seen in vaginal granulomatosis, microscopic polyangiitis, and Church-Ross syndrome. These are small vessel vasculitis. Which is the antibody in vaginal granulomatosis? Anybody? P or C alpha? C alpha. Vaginal granulomatosis has vaginal granulomatosis, and microscopic and Church-Ross syndrome P alpha. In microscopic and Church-Ross we have P alpha. Important antibody here. Next, now again a kidney biopsy. You have the light microscopic finding over here, and here you can see. If I can just zoom it out for you, on kidney biopsy light microscopy, you can see the basement membrane is appearing as if there are almost two basement membranes. There is a tram. So the appearance is known as, called as, and tram track appearance in kidney biopsy is a feature of MGM or MPGM? Tram track appearance is a feature of, it is MPGM, that is membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis. By this you can understand, here we will have features of both nephrotic as well as more features किसके होंगे? Here we will have mostly features of nephrotic syndrome. ठीक है? तो membranoproliferative glomerulonephritis, which type of appearance of kidney biopsy? Cramp-like appearance, or also called as double counter basement membrane. Also called as double counter basement membrane. Here you can see nephrotic as well as nephritic features. More commonly, nephrotic features. So here on kidney biopsy, please remember, I will find basement membrane thickening, which is a feature of nephrotic syndrome. And second, I will also find endocapillary proliferation. Second, I will also find endocapillary and mesangial proliferation, which is a feature of nephritic syndrome. समझ गए? No issues with this. Important. Next, talking about this condition where you have subepithelial deposits. Here you can see there are subepithelial deposits. Okay, these subepithelial deposits are IgG and C3 type. So IgG and C3 deposits in an elderly patient is suggestive of. It is suggestive of the diagnosis in this condition would be membranous glomerulonephritis. And this subepithelial IgG and C3 deposits give a characteristic appearance known as Shabash. Spike and who was the one to answer? It is the spike and dome appearance. See, spike and dome appearance. Important. So please remember, guys, if an elderly patient presents to you and kidney biopsy shows subepithelial IgG and C3 deposit, this appearance is called as spike and dome appearance. Kidney biopsy is a feature of. It is a feature of membranous glomerulonephritis. So can anybody tell me membranous glomerulonephritis is a nephrotic syndrome or a nephritis? It is a nephrotic syndrome. It is a, and rather it is the most common cause of nephrotic syndrome in. The most common cause of nephrotic syndrome in elderly. FMGE and follower. Okay, short. Most common cause of nephrotic syndrome in elderly. Most common cause of nephrotic syndrome in elderly. MGM में kidney biopsy shows. No issues. Now, please tell me the marker of MGM. It is anti-phospholipase A2 receptor. Okay, anti-PLA2 receptor. Okay, anti-PLA2 receptor antibodies are found. So the primary MGM, the cause is autoimmune due to production of these anti-phospholipase A2 receptor, and secondary MGM is associated with tumors. बहुत बार ये बोलेंगे, they will give you a history of tumors or malignancy in the patient or some infections as well. So the most common glomerulonephritis associated with malignancy is MGM. Most common glomerulonephritis associated with malignancy is MGM. Most common glomerulonephritis associated with infection is. So infection है, tumors है, malignancy है. The answer is more likely to be MGM. ठीक है? And kidney biopsy shows spike and dome appearance along with basement membrane thickening would be seen. ठीक है? No issues with this. Therefore, the name membranous glomerulonephritis. Next, here you can see again a kidney biopsy, light microscopic picture hai, and some part of the glomerulus is affected. Okay, some area is affected. That means focal area hai. Okay, and some segments of the glomerulus are affected. This is called as focal segmental glomerulosclerosis. So here there would be fibrosis or sclerosis in the glomerulus, right? So it is called as focal segmental glomerulosclerosis, and it is a type of nephrotic syndrome. Rather, it is the most common cause of nephrotic syndrome in adults. It is the most common cause of nephrotic syndrome in adults, right? Primary FSGS is usually idiopathic. It does not have a known cause. But secondary FSGS is associated with multiple conditions. And the most important one is actually HIV. When FSGS is seen in cases of HIV, it will have the worst prognosis. If FSGS is seen in patients of HIV, it will have the worst prognosis. And this variety of FSGS is called as collapsing FSGS. This type of FSGS is called as, and it will have the worst prognosis. The other conditions which can be associated with secondary FSGS would be reflux nephropathy, Hodgkin's lymphoma, heroin abuse, sickle cell anemia. Okay, multiple other conditions can be seen. Okay, but the important you need to remember is in which variety would be seen, and it will have the no issues with this. Drug of choice बता दो FSGS के लिए ना. FSGS में तुम cyclophosphamide दोगे. तो हमने ये लिखवाना होगा the drug of choice for FSGS are steroid. If the patient is steroid resistant, then the drug of choice would be cyclophosphamide or mycophenolate mofetil. ठीक है, the drug of choice for FSGS, drug of choice for FSGS, if steroid resistant then, important side effect of cyclophosphamide is hemorrhagic cystitis, and drug of choice to prevent hemorrhagic cystitis is asthma. Important. ठीक है, no issues with this. याद रख लेना. Moving further, a child presents to you. ठीक है, a child mostly between 2 to 8 years of age group presents to you with generalized edema. Generalized edema is called as anasarca. Along with that, she also has puffy eyes. This is a characteristic picture, uncharacteristic finding. Puffy eyes would be seen. There would be vulval edema, scrotal edema, pedal edema, and generalized swelling. All of these features. These are more likely characteristic of which syndrome? Nephrotic or nephritis? Definitely it is characteristic of nephrotic. And please tell me the most common cause of nephrotic syndrome in children is? Diagnosis in this condition would be minimal change disease. It is also called as lymphoid nephrosis. It is also called as and it is also called as nil lesion disease. Why it is called as nil lesion disease? Because on kidney biopsy light microscopic picture there would be no change. There would be or the kidney biopsy light microscopy finding would be absolutely normal. But on electron microscopy we can find there would be effacement of foot processes of podocytes. ठीक है, effacement of ठीक है, flattening हो जाती है. Now please tell me what is seen on biopsy of collapsing FSGS. This is important. Biopsy of collapsing FSGS will show us effacement तो देखेंगे, उसके अलावा important. So in collapsing FSGS, guys, please remember the biopsy picture will show us podocyte hyperplasia. It will show us podocyte. So podocyte hyperplasia seen in this form. Podocyte hyperplasia seen in this form. And effacement of foot process of podocytes is seen in this form. Effacement of foot process of podocytes is seen in this form. On which finding? Electron microscopy. Light microscopy shows. Therefore, it is called as nil lesion disease or minimal change disease. No issues with this. Important. It is also called as lipoid nephrosis because there would be loss of lipid droplets in the urine. Lipid urea would be there, right? Important. Please tell me now. What is the drug of choice for MCD? Important from pediatrics. Okay. पहले तो ये बता दो. In MCD also there would be protein loss, but predominantly which proteins would be lost? Albumin, and this type of protein loss is called as. So selective proteinuria is a feature of. Selective proteinuria is a feature of. Selective proteinuria is a feature of minimal change disease, and non-selective proteinuria is seen as. बच्चों में selective, बुढ़ों में non-selective. So MGN में there would be non-selective proteinuria. ठीक है? Drug of choice, all of you are right. The drug of choice for MCD would be steroids. Okay, the drug of choice would be steroids. Which steroid is given? Prednisolone. How many weeks? 8 weeks. It is usually given for 8 weeks, and then we will taper the dose. That is, we will gradually stop steroids in the patient. Okay. And if the patient develops steroid toxicity, then the drug of choice would be. If the patient develops steroid toxicity, then the drug of choice is cyclophosphamide. Okay, so this is about steroid dependent nephrotic syndrome. ठीक है, steroid dependent nephrotic syndrome की अगर मैं बात करूं, drug of choice are steroid, but if steroid toxicity develops, then cyclophosphamide. And if I talk about steroid resistant nephrotic syndrome, then right here I will give cycloserine inhibitors, cyclonurine inhibitors, calcinurine inhibitors. These are cyclosporine, calcinurine inhibitors like steroid dependent nephrotic syndrome, drug of choice, steroid toxicity, then steroid resistant nephrotic syndrome, drug of choice, cyclosporine not an option, tacrolimus. It is tacrolimus, दूसरा नाम, ठीक है. Sometimes in NEET PG cyclosporine was not an option, but tacrolimus was the other drug. It is also a calcinurine inhibitor. No issues with NCD now. Important question from PD as well. Moving further, easy. Question number 19 says, a 19-year-old patient with malar rash, joint pain, and photosensitivity. Kidney biopsy shows. So, a young adolescent female presenting to you with erythematous rash on the cheek, that is called a malar or a butterfly rash. Diagnosis of systemic lupus erythematosus or SLE. Along with that, the patient will complain of joint pain. This joint pain is the most common manifestation in SLE. If they ask you, most common manifestation in SLE, answer is arthralgia or joint pain. This joint pain is due to is it synovitis or arthritis? Synovitis. New addition of calcium cells, it is synovitis. The answer should be synovitis. Arthritis तब बोलोगे when there would be deformities in the patient. SLE does not cause deformities, so it is synovitis. ठीक है? So the most common manifestation of SLE is synovitis, and it causes the joint pain. And there would be photosensitivity. Apart from that, we will discuss in SLE all of those. One of the important, there would be other all multisystemic disease there, so there would be multiple systemic manifestations. One of the important organ affected is the kidney. And in kidney, SLE में क्या होगा? There would be lupus. There would be lupus nephritis, right? Lupus nephritis occurs. And if a biopsy of lupus nephritis is taken, it will show us wire root lesions. Which type of lesions are seen? Wire root lesions are seen. Important. ठीक है? So kidney biopsy of lupus nephritis shows. Kidney biopsy of lupus nephritis shows. And lupus nephritis is seen in which disease? Lupus nephritis is seen in SLE. Drug of choice, anybody? Again, steroid. The drug of choice here would also be steroid. Now, please tell me, guys, the most common cause of death in SLE patients usually in the early decades or when the patient is undergoing treatment. So now the treatment drug of choice for SLE is steroid. So long-term steroids will lead to immunocompromised rates, right? And therefore the patient is at a high risk of developing recurrent infection. So the most common cause of death in SLE, usually in the earlier decades of life, or when the patient is undertaking treatment, answer is infection. The most common cause of death in SLE, infection. Then most common cause of death in SLE after 45 years of age group, accelerated atherosclerosis. After 45 years, early decade, patient on treatment. Most common cause of death in cases of active SLE. Now your answer should be most common cause of death in cases of active SLE. It would be active means the disease is progressing. The answer should be lupus nephritis or renal failure. Okay, most common cause of death in active SLE. Most common cause of death in active SLE. Most common cause of death in active SLE. No issues with this. Important है याद रखना one liners आते हैं. Okay. Then we will move to the next one. उसके पहले nephrotic जल्दी से रिवाइज करते हैं. ठीक है. Random question सबने correct बोलना है. Mesangial proliferation on kidney biopsy. Disease का नाम बोल दो. Mesangial proliferation on kidney biopsy. Mesangial proliferation. Mesangial IgG and C3 deposit. the ribbon like deposit. Type 1 artesian is which type of hypersensitivity? Type 2. Good question there. Type 2 hypersensitivity. Which antibodies are formed? Anti-GBM antibodies. Type 2 artesian is which type of hypersensitivity? Type 3 hypersensitivity. Because it is immune complex mediated. PSGN and IgR which type of hypersensitivity? Type 3 immune complex mediated agent. ठीक है? Type 3 hypersensitivity. Now, most common wale jaldi se. Most common cause of nephritic syndrome in children. Most common cause of nephritic syndrome in children. Most common cause of nephritic syndrome in adults. Most common cause of nephritic syndrome in adults. Most common cause of nephrotic syndrome in children. MCD. Most common cause of nephrotic syndrome in children. Most common cause of nephrotic syndrome in children. Most common cause of nephrotic syndrome in adults. Most common cause of nephrotic syndrome in elderly. MGN. MGN पे kidney biopsy shows which appearance? MGN kidney biopsy Hypokalemia. MGN kidney biopsy shows? MGN kidney biopsy shows? Immunofluorescence or SARS का appearance is seen है? Immunofluorescence का SARS का appearance is seen है? Lumpy bumpy appearance is seen है? Yes. No issues with this? Done. Nephrotic समझ गए? Nephritis समझ गए? Hematuria? Hypokalemia? More than 3.5 grams per day? Less than 3.5 grams per day? Hypertension? Edema? Lipiduria? Hyperkalemia? Moving further, next one. A patient of type 2 diabetes mellitus comes to you with a microvascular complication, and that is diabetic nephropathy. The answer is diabetic. And as we know, diabetic nephropathy is the most common cause for anybody. Diabetic nephropathy is the most common cause of CKD or renal transplant. Most common cause of CKD is? Most common cause of CKD is? Most common cause of CKD is? Most common cause of renal transplant is? Most common cause of renal transplant is? Most important risk factor for diabetic nephropathy is? Most important risk factor. Right, it is duration of diabetes. It is duration of diabetes. Most important risk factor is? Most important risk factor is? Second most is poor HbA1c control. Second most important is? So in question if it comes, पहले आया था, so all of us tend to mark poor HbA1c control. नहीं. The most important is duration of diabetes followed by poor HbA1c control. No issues with this. HbA1c more than 7% continuously is actually a risk factor for any of the microvascular complications. And the most common microvascular complication of diabetes is? Most common complication of diabetes is diabetic nephropathy. More commoner than diabetic neuropathy or diabetic retinopathy. Okay? And it causes chronic kidney disease in the patient. Okay, if I talk about the kidney biopsy in a patient of diabetic nephropathy, which is the most common lesion. क्या बोल रहे हो? मैंने क्या पूछा? आंसर एक बार मैंने most common पूछा. Did I ask you about most characteristic or most specific kidney biopsy finding? The answer should be diffuse glomerulosclerosis. Answer should be? The answer should be? So most common kidney biopsy finding in diabetic nephropathy is? Most common kidney biopsy finding in diabetic nephropathy is? If I ask you most characteristic or most specific kidney biopsy finding, then nodular glomerulosclerosis, which is also known as Kimelstein-Wilson nodules. Kimelstein, wire loop regions are seen in? Wire loop regions are seen in? Kimelstein-Wilson nodules are seen in? No issues. Most common, diffuse glomerulosclerosis. Most characteristic or most specific, Kimelstein-Wilson nodules. कोई issue इसमें? नहीं है, ठीक है. Anybody earliest lab parameter to be affected in diabetic nephropathy? Earliest lab parameter to be affected? Increase in GFR or decrease in GFR? Increase in GFR. There would be increase in GFR, important. Followed by microalbuminuria. Followed by microalbuminuria. So there would be loss of albumin in the urine. ठीक है, no issues with this. Diabetic nephropathy के बारे में एटलीस्ट इतनी चीजें पता होनी चाहिए तुम्हें, ठीक है. ड्रग ऑफ चॉइस फॉर दिस वुड बी, याद रखना, इफ देयर इज proteinuria in the patient, एक बार बता देता हूं. ड्रग ऑफ चॉइस फॉर proteinuria are steroid. ड्रग ऑफ चॉइस फॉर proteinuria are ड्रग ऑफ चॉइस फॉर proteinuria are if the patient is suffering from hypertension and nephritic syndrome, drug of choice would be ACE inhibitor. Therefore, the patient of diabetic nephropathy, usually he is suffering from hypertension and the drug of choice would be the drug of choice for hypertension in diabetic nephropathy patient. Otherwise it is drug of choice for hypertension in diabetic nephropathy is drug of choice for hypertension. Otherwise drug of choice for hypertension are thiazide. But in diabetic nephropathy the answer changes to in diabetic nephropathy the answer changes to if ACE inhibitors are not an option, then the answer should be ARB. The answer should be angiotensin receptor blockers. ACE inhibitors are drugs like captopril, enalapril, pril drugs. Okay, and the most important side effect of ACE inhibitors is बार question आता है. Most important side effect is it is due to increase in which substance? Increase in which substance, guys? Pharma भी कर रहे हो ना? Most important side effect of ACE inhibitor. Diabetic, angioedema. They are due to elevated levels of bradykinin. They are due to elevated levels of bradykinin. ठीक है? Important है, बार-बार क्वेश्चन आता है. जब स्पेलिंग के साथ पेशेंट आएगा तुम्हारे पास या कम के पास, लिसन, हाँ. ARB के अगर मैं बात करूँ, angiotensin receptor blockers की, those are drugs like sartan. Those are drugs like sartan. Okay, by sartan, all of these. No issues with this. Important, याद रखना. Then talking about CKD अगर है ये टॉपिक कर लेते हैं. Important. Please remember, CKD के पेशेंट में there would be grading. Normal GFR कितना होता है? 125 ml per ml. 125 ml per minute per 1.73 meters square. 125 ml बोल दो. Normal GFR. When do we call it CKD then? CKD, chronic kidney disease, is said when the GFR is less than 60, Allison says, some books say less than 90 ml per minute per 1.73 meters square, along with proteinuria, for a period of 3 months. For a period of 3 months. Definition भी पूछी जाती है, chronic bronchitis का भी ऐसा ही definition एग्जाम में आना था. And they ask you इसकी ये क्या होगा? Which is the most important feature of this? तो यही होता है. Please remember, chronic kidney disease with the GFR of less than 60 ml per minute, along with proteinuria for a period of 3 months. ठीक है? Grading, grade 1 is less than 90. Grade 1 is less than 90. Grade 2 is 60 to 89. Grade 2 is grade 3 is 30 to 59. Grade 3 is grade 4 is 15 to 29. Grade 4 is and grade 5 is grade 5 is अगर तुम्हें लगता है CKD का नहीं पूछ सकते, I tell you, August examination from pediatrics, there was a question on stages of acute kidney injury. They gave a case and they asked us which stage of acute kidney injury the patient belongs to. ठीक है? So it is a recall based question important. ठीक है? CKD के stages याद रख लेना. Less than 15 is stage 5. When do we plan renal transplantation in this patient? Plan. In grade 4 we plan renal transplantation. When do we plan? And we perform renal transplantation in grade 5. ठीक है? And patient patient किस पे जाता है? In grade 4 or grade 5 the patient would be on hemodialysis. The patient would be on hemodialysis. Hemodialysis can be either 2 or 3 times a week depending on the patient. Okay, the severity of the disease. No issues with that. Important याद रख लेना. उसके बाद एक क्या आएगा डिस्कस करेंगे. Before that ABCDE के ये सबको याद रखने की जरूरत नहीं है. इंपॉर्टेंट चीजें बता रहा हूँ. If you don't remember this, check it. But अगर इंपॉर्टेंट चीजें याद रखना चाहते हो रख सकते हो. In CKD patients, first of all, that means HbA1c control is there. And HbA1c control के लिए which drug is given in CKD patient? Which drug is to be given for diabetes or HbA1c patient of CKD? यही बताना चाहता हूँ. This is important and most of us make this mistake. Metformin is not given in cases of CKD. याद रखना. Metformin is excreted via kidney and therefore it is not recommended in patients of chronic kidney disease. For HbA1c control, we give insulin therapy. Sometimes we give standard glipizide, but otherwise we send the patient on insulin. Okay. So for HbA1c control in CKD we give blood pressure control के लिए we give blood pressure control के लिए cholesterol के लिए hyperlipidemia के लिए statin. Hyperlipidemia के drug of choice are statin. Then the patient will also have low vitamin D3 levels because vitamin D is synthesized by kidney, mainly the PCT cells, right? And there would be low vitamin D levels, and that will lead to high phosphate levels in the patient. And for high phosphate levels, cevalimar is the drug which is given. ठीक है, drug of choice for hyperphosphatemia, cevalimar. Drug of choice for hyperphosphatemia, cevalimar. ठीक है. Electrolytes are important यार, कभी भी आ सकता है. Drug of choice for hyperphosphatemia है cevalimar. Then now erythropoietin is also prepared or produced by kidney. Therefore, the patients of CKD lead to anemia. The patients of CKD are at a higher risk of developing anemia because erythropoietin production falls down, right? And there is a higher risk of chronic hyperkalemia. There is a higher risk of chronic hyperkalemia. What is the drug of choice for chronic hyperkalemia? See, if it is chronic, we need to give a long-term treatment and it should be oral drug. Potassium chloride मत बोलना, sorry, calcium gluconate मत बोलना. It is the oral drug known as patyromine. So for chronic hyperkalemia, the drug of choice is chronic hyperkalemia. The drug of choice is chronic hyperkalemia. The drug of choice is oral patyromine is given to the patient. No issues with this. Important चीजें याद रख लो बस. बाकी check it. बाकी 2-3 चीजें तो तुम्हें पता ही थी. बस metformin नहीं देना है. Rather send the patient on insulin. Then now if a patient of malignant hypertension comes to you, a patient of malignant hypertension comes to you, that means the patient is in hypertensive crisis. BP more than 180 or BP more than 200 usually, right? In this, what can be seen? In the kidney biopsy, we can see there would be narrowing of the arterial lumen and there would be this kind of thickening sin. Okay, so thickening of the arteriolar wall is seen. This is kind of which appearance? This is called as the onion peel or onion skin appearance. So onion peel appearance or onion skin appearance in kidney biopsy is a feature of onion peel appearance in kidney biopsy is a feature of and malignant hypertension is also one of the most important reasons for acute kidney injury. Acute kidney injury का प्रयोग, that means the patient's condition deteriorated very suddenly or very rapidly within 1 or 2 days time. That is called as acute kidney injury. Most important factor क्या होगा? To assess acute kidney injury, most important lab parameter urea or serum creatinine. Most important lab parameter is serum creatinine. It could be anything. ठीक है, एक क्या आएगा ग्रेड आया था, so all of you are aware of एक क्या ग्रेड है, very good. ग्रेड आया था, पीडीएफ से भी आता है, एनसीए भी आता है. So grading, I'll write it over here. ठीक है, तो एक क्या है कि grade, please remember there are stage 1, stage 2 and stage 3 and it is usually based on the serum creatinine value, urine output and the duration. Sorry. In grade 1, please remember, here the serum creat, this is the urine output, and this is the duration. Okay? So stage 1 means serum creatinine value more than 1.5 to 1.9 times the normal. 1.5 to 1.9 times the normal value. What is the normal value of serum creatinine? 0.5 till 1.5. Maximum range goes up to 0.5 till 1.5 milliequivalents per liter. Right? So serum creatinine value 1.5 to 1.9 times the normal. Urine output less than 0.5. Urine output less than 0.5 ml per kg per hour for a duration of 6 hours. For a duration of 6 hours. Next, serum creat value between 2 to 2.9 times the normal value. Urine output again less than 0.5 ml per kg per hour for a duration of 12 hours. And lastly, serum creatinine value more than 3 times the normal creatinine value. Urine output less than 0.3 ml per kg per hour for a duration of 24 hours. For a duration of 24 hours. समझ गए? जल्दी से करके रख लेंगे, फालतू में टाइम नहीं कमाना है. Stage 1 serum creat, urine output, duration. Stage 2 serum creat, urine output, duration. Stage 3 serum creat, more than 3 times. Urine output, duration. ठीक है, इंपॉर्टेंट है, याद रख लो. That's it. इसके अलावा AKI में ज्यादा कुछ याद नहीं रखना है. Otherwise, in acute kidney injury, you do symptomatic management of the patient. Okay, there would be electrolyte disturbances, and we'll discuss electrolyte disturbances now. Before moving to electrolyte disturbances, please let me know what does this picture suggest you of. ये picture पूछी गई थी यार. Multiple cysts in the kidney, in the medulla as well as the cortex. This is the condition of polycystic kidney disease, and mainly it is which type of inheritance? Genetic होता है mainly, and which type of inheritance? Mostly it is autosomal dominant polycystic kidney disease. Which gene mutations? Chromosome number? पहले 4 या पहले 16? Chromosome number 16 and chromosome number? Which gene on chromosome number 16? PKD1, which encodes for polycystin 1 protein, and which gene on chromosome number 4? PKD2, which encodes for polycystin 2 protein. No issues with this? Important. Okay? So autosomal dominant polycystic kidney disease, which gene mutation? PKD1 and PKD1 on chromosome, PKD1 on chromosome, PKD2 on PKD2 on. No issues? Okay, important. Now here, what is the most common cause of death? Anybody? Most common cause of death. Definitely the most common symptom in these patients, when there will be rupture or there will be hemorrhage in this disease, the most common symptom would be flat pain. Most common symptom would be the most common cause of death is anybody? Question has been asked. Hypertension related complication. Okay, most common cause of death is hypertension related complication. No issues with PKD. Important, it can be autosomal recessive, it can be autosomal dominant. But more common is autosomal PKD1 and PKD1 on chromosome, PKD2 on chromosome. What is the treatment of choice? Drug of choice, if they ask you, answer would be hypertension. So, drug of choice would be treatment of choice would be renal transplant in the patient. Now, important points about renal transplant, guys. Please tell me, for renal transplantation, HLA matching is mandatory or not? Yes, HLA matching and blood group matching both are mandatory. Please remember, this was the question. HLA matching and blood group matching both are mandatory in case of renal transplantation. Which kidney is preferred from the donor? Right or left? Left kidney is preferred from the donor. Why? Left renal vein is longer. Left renal vein is, therefore which kidney is preferred? And it is placed in which fossa? It is placed in which fossa? So left kidney is preferred from the donor, and it is usually placed in the right iliac fossa. It is placed where? Because it can be easily removed if there is any rejection, right? Now, pathos question. Rejection, graft rejection. Most common cause of 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 graft versus host disease. Again. Rejections can be of three types. Hyperacute rejection, which occurs within minutes. It is which type of hypersensitivity? Hyperacute rejection is? Acute rejection. These are symptoms will develop within 1 to 6 months of transplant. Acute rejection is type? Delayed. So delayed or self-mediated immunity is usually type 4 hypersensitivity. समझ गए? Hyperacute type, acute type, and chronic when symptoms appear after 6 months of renal transplant. Chronic is again type 2, 4, 4 याद रखना है. Hyperacute, acute, chronic. ठीक है? So these are actually allogenic renal transplantation. What do we mean by allogenic? Same species. Allogenic means from the question अगर नहीं पता हो ये 4 पॉइंट तो allogenic from the family, mother, father, daughter, sister, anybody. Okay. From same species, mother, father, anybody. It is allogenic transplant. ठीक है? Isograft or isotransplant means identical. Isograft means from the iso means from the identical or monozygotic twins. It is not dizygotic either. If it is a dizygotic twin, it could be called as a allograft. If it is dizygotic twin, it is called as a. If it is a monozygotic twin, it could be called as a isograft. ठीक है? I for identical twin, I for isograft. Autograft means own body. ठीक है? Autograft means from one's own body. And xenograft means from the different species that is animal. Xenograft means from jaldi. Identical twins. One's own body. Same species. Different species. ये important question है पाठों का. Now, talking about this condition, guys, here you can see a peripheral blood smear is seen, and on peripheral blood smear we can see these RBCs are broken down. These broken down RBCs are called as हेमैट नहीं आया अब तक, रीनल ही चल रहा है. सिकल दिख रहा है तुम्हें ये? शाबाश. Who was that? These are called as helmet cells. Okay, these are called as helmet cells, also known as schistocytes. These are also called as schistocytes. Please remember. And schistocytes are seen in which type of anemia? Anybody? Maha. Schistocytes are a feature of microangiopathic hemolytic anemia. These are seen in schistocytes are seen in Maha. So Maha के दो causes हो सकते हैं. Please remember, because they are related to kidney, so I am discussing over here. One cause can be TTP, that is thrombocytopenic purpura. So in body there would be multiple thrombus which would be formed, and when these RBCs will pass from these microthrombi, they would be damaged, and there would be formation of. So one of the reasons of Maha is TTP. One of the reasons of Maha is TTP. And the other most important reason related to kidney is actually HUS. What do we mean by HUS? Hemolytic uremic syndrome. Okay, HUS means hemolytic uremic syndrome. In hemolytic uremic syndrome, it is due to an organism known as anybody. The patient would have gastroenteritis first, and then now the patient will present you with kidney symptoms. इसका मतलब है the patient has developed hemolytic uremic syndrome, and on peripheral blood smear it will show schistocytes. ठीक है? So this it is due to E. coli which stream? This was asked. One liner from micro also. O157H2 H7. O157H2 H7. So hemolytic uremic syndrome is caused by which organism? E. coli. O157H2 O157H2 confused हो जाते हो जो ऑप्शन में सब सिमिलर E. coli. They will not give you another organism. They will always give you E. coli. Please remember, it is enterohemorrhagic strain of E. coli, which is called as E. coli O157H2 L7, which is known to cause hemolytic uremic syndrome. What do we mean by uremia? Uremia is due to accumulation of urea or elevated levels of blood urea nitrogen. It can be seen in cases of chronic kidney disease. It can also be seen in cases of hemolytic uremic syndrome, and mainly it is a feature of acute kidney injury. So if there is elevated levels of urea, it can cause uremic pericarditis in the patient. So there would be chest pain in the patient. It can also lead to uremic encephalopathy in the patient, right? And uremic encephalopathy jab hoti hai, the patient will present with this kind of tremors. What are these tremors called as? Flapping tremors. So now asterixis, important from neuro also, important from kidney also. These flapping tremors are called as asterixis. ठीक है? Flapping tremors are called as asterixis, which would be seen in case of uremic encephalopathy. Asterixis is seen in case of uremic encephalopathy. No issue with this? याद रखो. Now moving further, TTP is usually self-limiting. HOS में हम treatment देते हैं, antibiotics दे देते हैं patient. Important चीजें बता दिए, बस important चीजें याद रख लो. Moving further, talking about a patient. इसमें मुझे लगता है doubt है, all of you might not be knowing this, ठीक है? ज़्यादा important नहीं है, but जिस तरह से pattern बदल रहा है, इनको uncommon चीजें पूछनी है, so we never know they can ask you even this. Important चीजें बताऊंगा, बस उतना याद रखना. Patient with metabolic acidosis. Okay, metabolic acidosis means H plus is not being excreted out properly. Next, there is bicarbonate urea. That means the bicarbonates are not being excreted out. Glucose urea. That means the glucose is not being, the glucose is actually excreted out. What is the diagnosis and which part of nephron is affected? Right. So as we know, for sodium absorption, maximum sodium absorption occurs from question 1 line of the video. Maximum sodium absorption occurs from maximum sodium absorption occurs from maximum bicarbonate absorption occurs from maximum bicarbonate absorption occurs from maximum glucose absorption occurs from again maximum amino acid absorption again. So in this patient, as the PCP is damaged, therefore the patient will have features of bicarbonate urea, amino acid urea, glucose urea, all of these features. And H plus is usually excreted out by the PCP. But as this PCP is damaged, H plus would not be excreted out; it would be rather retained inside the body. That causes metabolic acidosis. Okay? And there would also be hypokalemia in the patient. All of these features are seen in. So the part of nephron affected is PCT, important is सबसे ज़्यादा, and the diagnosis in this condition is renal tubular acidosis. The diagnosis is renal tubular acidosis. So due to some damage to the renal tubules, the patient develops acidosis. This is called as RTA, or renal tubular acidosis. Which type, anybody? There are 3 types. Most common type of RTA is usually RTA type 4. Most common is RTA type 4. Here it is RTA type 2. Here it is RTA type 2 and RTA type 1 भी होता है. So याद रख लो important चीजें. RTA type 2 में which part of the nephron is damaged? RTA type 2 में RTA type 2 में RTA type 1 में DCT. RTA type 1 में DCT is damaged, right? And RTA type 4 में usually there is aldosterone resistance in the patient. There would be aldosterone resistance in the patient, so that will cause salt wasting would be there usually. Okay, so this is important, right? And in RTA, ये differentiate कैसे करना है? इसमें भी hypokalemia होता है, but इसमें hyperkalemia होगा. No issues with this? I hope so. Acidosis तो सब में होगा. All of them are renal acidosis. So metabolic acidosis is seen in all of them. If bicarbonates, glucose, amino acids are being lost, it is RTA type 2. Okay, please remember. If there is loss of salt and water, it is RTA type 4, and if there is even hyperkalemia. Okay, no issues with this. Moving further now. Now, talking about metabolic acidosis, guys. I discussed about ABG analysis in the pulmo part, but just talking about the examples over here because it is related. So metabolic acidosis can be a normal anion gap metabolic acidosis or a high anion gap metabolic acidosis. Normal anion gap कितना होता है? Normal anion gap is between, you can say, a range of 8 to 16 milliequivalents. Normal anion gap is positive ions minus the negative ions, that is anion gap. ठीक है? Important. So normal anion gap metabolic acidosis का mnemonic क्या है? Doctor use. ठीक है? So D goes for diarrhea. D goes for, R goes for renal tubular acidosis. R goes for, F goes for fistula. F goes for, U goes for ureterosigmoidostomy. It goes for ureterosigmoidostomy. Whereas high anion gap metabolic acidosis, the mnemonic is KILD. ठीक है? K goes for ketoacidosis. That means diabetic ketoacidosis usually. U goes for uremia. That means renal failure. L goes for lactic acidosis. And T goes for toxins like methanol poisoning. Toxins like, तो रिवाइज करते हैं जल्दी से. Normal anion gap metabolic acidosis. Mnemonic is Dr. Q. D for R for F for use for high anion gap metabolic acidosis. Mnemonic is KILD. D for 2 for L for and T for like. ठीक है? ये एग्जांपल्स पूछेंगे. Which among the following is a high anion gap metabolic acidosis? All of these would be given except कोई भी इसमें से एक दिया होगा आंसर. ठीक है? तो इस टाइप से क्वेश्चन आता है. Moving further, and the most important part, अगर फ्रेश होना है 1 मिनट का ब्रेक लेके फ्रेश हो जाओ. हर बार का क्वेश्चन है टॉपिक से, and I want you to be very particular about this topic. On just fingertips ये टॉपिक होना चाहिए. इलेक्ट्रोलाइट डिस्ट्रेस. 10 मिनट. अरे किडनी करके एक ब्रेक मिलेगा ही. ये इफ्तार का आज 6:30 है. ओके ठीक है, 10 मिनट का दे देंगे तो ये खत्म करके, क्योंकि इसके बाद न्यूरो भी काफी बड़ा है. न्यूरो में मुझे इसमें तो ड्रग्स वगैरह है नहीं, इसमें बस डायूरेटिक्स है. ठीक है, बट न्यूरो में ड्रग्स भी है, फार्मा का कंपोनेंट भी मिल चुका है. सो 2-3 मिनट का ब्रेक ले लो आराम से, कोई दिक्कत नहीं है. बट आई वांट गुड आंसर्स फॉर दिस नाउ. इलेक्ट्रोलाइट्स, आई होप ऑल ऑफ यू हैव कवर्ड them.
कार्डियो कब लेंगे, मतलब एंड में ही लेंगे ना सर, क्योंकि ईसीजी एक हो जाता है. थर्ड सेशन
मैं कार्डियो पहले ले लूंगा और फिर दूसरा जब स्टार्ट होगा तब कार्डियो लूंगा, और नेक्स्ट जो भी होगा उसके बाद.
सर अभी मतलब सिर्फ
आई एम कवरिंग मेडिसिन पैटर्न का
पीएसएम
का अलग से सेशन है.
पीएसएम
का अलग से सेशन लेंगे.
सर अभी आपका पीजी का भी एग्जाम आ रहा है, फिर कैसे आप
पढ़ना मुझे भी है, तुम्हें भी है, साथ में ही पढ़ना.
मुझे लगा कल कोमल से बात हुई थी, कोमल ने कहा कि आप पीजी दे रहे हो, तो मैं बोला मतलब कि कैसे करेगी इस पर क्या पता, मतलब सर तो पढ़ना भी होगा, नहीं पढ़ा भी नहीं होगा।
Get back. क्या हुआ? यहाँ पे ECG is showing what? क्या दिख रहा है तुम्हें? In chest leads also, in the standard reads also, we can see the T waves are tall. So tall tented T waves दिख रहे हैं, right? There would be tall tented T waves. Along with that, there can be other features like broad QRS complexes, prolonged QT interval, and ST elevation. All of these features are seen in cases of hyperkalemia. These are seen in cases of increased level of serum potassium. Normal potassium level, anybody? 3.5 to 5 milliequivalent per liter. 5.5 बोलते हैं, but lab value 5 आते हैं, ठीक है? 5.5 के बाद we usually start treatment in the patient. So important please याद रख लो, hyperkalemia. Potassium value is normal potassium value is in cases of hyperkalemia. What are the ECG findings? First is broad QRS complex. Second is prolonged QT interval. Third is and fourth is tall tented T wave. एक ही याद रहता है हम सबको, tall tented T wave, but कभी-कभी ECG में नहीं दिख जाता हो, तो इसलिए घबराना नहीं. All of the others are also findings of hyperkalemia, right? In hyperkalemia, when the potassium level will exceed 8 milliequivalent, the patient will suffer from which type of cardiac arrest? The patient will suffer from diastolic arrest. Systolic arrest is seen in cases of hypercalcemia. Systolic arrest is seen in cases of and diastolic arrest in cases of hyperkalemia. ठीक है? Because याद रखो एक simple सा फंडा है. Sodium, potassium are responsible for contraction. Potassium is responsible for relaxation. So it will cause diastole. Okay? Hyperkalemia will cause diastolic arrest in the patient. What is the drug of choice or treatment of choice? Anybody? Drug of choice for hyperkalemia, acute hyperkalemia. It is IV 10% calcium gluconate. So most commonly we use calcium gluconate, but the best one is calcium chloride. Usually वो नहीं तुम्हें confuse करेंगे इसके साथ. At least remember calcium gluconate. So calcium क्या करेगा? It will antagonize the effects of potassium on the heart. It will save the patient. So it is actually a life-saving drug, but not specific. वो potassium की levels कम नहीं करेगा. It will not decrease serum potassium level. But why is the drug of choice? Because it is a life-saving drug. It will antagonize the effects of increased potassium on the heart. ठीक है? The drug of choice for hyperkalemia. Calcium gluconate. If they ask you the most specific drug for hyperkalemia, if they ask you the most effective or the most specific drug for hyperkalemia, yes, it is IV regular insulin. Because why it is most specific or most effective? Because it will send the potassium inside the cell. So mechanism of insulin, how does it decrease serum potassium level? So insulin will send potassium inside the cell. Therefore, it will decrease serum potassium level. Okay, so most effective drug for hyperkalemia is insulin, and only insulin which can be given IV is regular. सबको पता है? Important. So please remember, drug of choice for hyperkalemia, most effective drug for hyperkalemia. Along with that, definitely we can give a beta 2 agonist like salbutamol. So salbutamol nebulization can also be given to the patient. It will also cause same action like insulin, send potassium inside the cell. But insulin is more effective, therefore it is the most effective drug. The last question: most effective treatment or the treatment of choice? It is hemodialysis. Most effective treatment would be. Most effective drug would be. No issues with this. Hyperkalemia done. Next, ECG shows us what? So here you can see the ECG. First of all, it shows QT क्या दिखाएगा? Prolongation दिखाएगा, shortening दिखाएगा अभी. There would be QT shortening would be seen. Okay, there would be decreased QT interval. Next, ST depression and elevation. We can see there would be ST depression. So ST depression is seen. Okay, and lastly, the T waves. Here you can see the T waves are either absent. Okay, the T waves are either absent or they are inverted. So T waves are either absent or they are inverted. And lastly, the most important, here you can see instead of T waves, you can see a very prominent wave that is called as the U wave. A prominent U wave is seen. So the diagnosis in this condition would be, the diagnosis over here is hypokalemia. That means the potassium levels are low than normal. Okay. So hypokalemia में ECG findings क्या क्या है? First of all, QT shortening. First of all, there would be. Second, there would be. Second, there is. Third, there is T waves are absent or inverted or which waves? And there would be a prominent. These are features of hypokalemia. Potassium values are low. So therefore, the drug of choice would be. If definitely, please remember, if the patient has mild hypokalemia, orally the patient can take the drug, then it will be a oral potassium chloride known as POD. Okay? Otherwise, it is intravenous potassium chloride. So the drug of choice remains same, that is potassium chloride. Only if it is mild, it is oral. If the patient has moderate or severe hypokalemia, then it would be intravenous. What is the cause of death in cases of hypokalemia? In hyperkalemia, cause of death was. In hyperkalemia, cause of death was diastolic arrest. Hyperkalemia, cause of death was. Hyperkalemia, cause of death was. Hypokalemia, cause of death क्या होगा? It would be diaphragmatic paralysis. It would be diaphragmatic. What happens in hypokalemia? The main symptom of hypokalemia is muscle weakness, right? So please remember, cause of death in hyperkalemia is. Cause of death in hypokalemia is diaphragmatic paralysis leading to respiratory failure in the patient. No issues with this? Yeah. Drug of choice for hyperkalemia. Drug of choice for hypokalemia. And drug of choice for chronic hyperkalemia. Chronic hyperkalemia. Anti-wrong. Drug of choice for chronic hyperkalemia. Drug of choice for chronic hyperkalemia. Acute के लिए calcium gluconate. Chronic के लिए we discussed in kidney disease. It was anti-wrong. ठीक है? No issues with this. Therefore, potassium binding resins like zirconate can be given, but they are not the drug of choice. Enema also can be given potassium binding resins के साथ. ठीक है? But they are not the drug of choice. They are add-on drugs. Next, इस ECG में क्या दिख रहा है तुम्हें? इस ECG में क्या दिख रहा है? There is a prolonged QT interval. Okay, here you can see from Q to T the distance has been increased. So a prolonged QT interval is seen in cases of hypocalcemia. Prolonged QT interval is seen in cases of. So the diagnosis is hypocalcemia. Normal calcium levels are 9 to 11 milligram per cent. Normal calcium levels are. An important ECG finding of hypocalcemia is. Prolonged QT interval. If I talk about the important signs, here we are trying to irritate the facial nerve and there would be grimacing seen. This is known as which sign? Churostic sign. This is known as which sign? Churostic sign. Whereas in this condition you can see there is a carpopedal spasm. This carpopedal spasm is known as which sign? Carpopedal spasm is known as Trousseau sign. It is known as the Trousseau sign. No issues with this? So facial irritation पे which sign? Facial irritation पे carpopedal spasm is known as. So here actually in hypokalemia for all of these signs, the reason behind them is actually tetany. So the patient is suffering from tetany or hypocalcemia in this condition. And the most common cause of death, anybody? Right, laryngospasm. Most common cause of death is laryngospasm in this patient. No issue. Now बता दो जल्दी से drug of choice for hypocalcemia. Calcium less है तो क्या दोगे? Calcium दोगे. So again it is IV, 10% calcium. So calcium gluconate was the drug of choice for hypocalcemia and hyperkalemia. ठीक है, no issue. Next, इसमें क्या दिख रहा है हमें? Here we can find a small QT interval, right? Rather the T wave is overriding onto the QRS complex, right? A small QT interval is seen, and here you can see the Q wave is the T wave is almost overriding onto the QRS complex. This kind of feature where we have a QT shortening, it is a feature of hypercalcemia. It is seen in cases of hyper. What is the drug of choice for hypercalcemia? Here the cause of death मैंने बताया था पहले. Hyperkalemia, diastolic arrest. Hypercalcemia, systolic arrest. Hypercalcemia causes drug of choice क्या होगी? Calcium बढ़ा है उसको कम कर दो. Give a drug which will take calcium from the blood and deposit it in the bones. Loop diuretics will lead to loss of calcium definitely, but it is not the drug of choice. एक choice देनी हो तो ibandronate, that is bisphosphonates are the drug of choice. Definitely, patient, the first line management could be IV fluid to the patient. Okay, that will cause dilution. Okay, important. Apart from that, if they ask you the drug of choice, the answer should be ibandronate or bisphosphonate. ठीक है, important. No issues with this. जल्दी से एक बार ये चार करते हैं, फिर I go to sodium. ठीक है. Broad QRS complex, prolonged QT interval, ST and coordinated diagnosis would be hyperkalemia. Normal potassium value is when it goes beyond 8, it is called cause of death, hyperkalemia. Drug of choice for hyperkalemia. Most effective drug for hyperkalemia. Most effective drug for hyperkalemia. Most effective treatment for hyperkalemia. Most effective treatment for hyperkalemia. Hemodialysis. Drug of choice for chronic hyperkalemia and CKD. Drug of choice for chronic hyperkalemia and CKD. Next, there would be QT shortening, ST depression. T waves are absent or inverted, and the dominant Q wave on ECG. This suggests your cause of death is drug of choice is ACL. Prolonged QT interval on ECG shows the sign. Carbopetal spasm होना है. Cause suggests your there would be with sign on face. Carbopetal spasm is known as cause sign. Most common cause of death is drug of choice is calcium gluconate. Next, QT shortening is seen on ECG. Diagnosis is cause of death is drug of choice is bisphosphonate like ibandronate. No issues with this, right? Sodium. Most important, ये most common जो तुम्हारे पास आएगा patient जो hospitalized होगा. So if they ask you the most common electrolyte abnormality in a hospitalized patient, answer should be क्या? Hypo या hyper? Hyponatremia. The most common would be hyponatremia. Normal sodium values, anybody? Normal sodium values are 135 to 145 mg. Normal sodium values are. So if I talk about hyponatremia, that means decreased levels of serum sodium in the patient. It can be mild, moderate, severe again. Okay. If there is a severe hyponatremia, the patient can have cerebral edema, and that can lead to seizures in the patient. That can cause life-threatening seizures in the patient. If there is severe hyponatremia, sodium levels less than 125 milliequivalents per liter. No issues with this. अब ड्रग ऑफ चॉइस बता दो जल्दी से, हाइपोनेट्रीमिया। इट इज नॉर्मल सलाइन दोगे, you need sodium more na, sodium is more in hypertonic saline, that is 3% saline. Please remember, drug of choice for hyponatremia, hypertonic saline. Drug of choice for hyponatremia, drug of choice for hyponatremia, 3% saline is usually given, that is hypertonic saline. So excess of sodium is given to the patient. ठीक है, उसके पहले मैं आगे बढ़ूं, उसके पहले मुझे hypernatremia बता दो. Again please remember, hypernatremia or increased sodium values can also cause seizures in the patient. Okay, and when they will cause seizures when the value is more than 158 milliequivalents per liter. ठीक है, what is the drug of choice? So here now you will give a hypotonic fluid. Hypotonic fluid is IV 5% dextrose. Please remember. Lingual lactate again contains moderate amount of sodium. ठीक है, तो तुम पहले से hypernatremia patient में, so you will give a hypotonic fluid which contains less sodium. ठीक है, drug of choice for hyponatremia, drug of choice for hyponatremia, drug of choice for hypernatremia, 5% dextrose. No issues with this. Now hyponatremia के बस तीन चीजें जल्दी से बता देता हूँ. First of all, there can be hypovolemic hyponatremia. Hypovolemic hyponatremia. नाम से क्या पता चल रहा है? The total body water is decreased and the total body salt is also decreased. It would be seen when there is loss of water as well as sodium from the body. It is seen in cases of diarrhea, or the other is cerebral salt wasting syndrome. Next, yeah, excess of diuretics can also lead to this. Next is euvolemic hyponatremia. Euvolemic मतलब the total body water is, यही catch है, याद रखना. Though the name is euvolemic, the total body water would be increased in this patient and total body salt would be normal. याद रखना. So you will say total body salt तो normal है, तो hyponatremia कैसे? Please remember here the total body water is increasing, that is causing dilution of the plasma. So it is a dilutional hyponatremia, which is also called as euvolemic hyponatremia, and it is seen in cases of SIADS. It is seen in cases of syndrome of inappropriate ADS secretion, because ADS only leads to retention of water and not sodium. Okay, ADS only leads to retention of water. And the last one is hypervolemic hyponatremia. Okay, hypervolemic hyponatremia. Here the total body water would be increased. Total body salt is also increased, but the amount in which both of them which they increase is actually very different. Okay, the proportion is not maintained. So total body water तो बहुत ज़्यादा बढ़ रहा है, but total body salt थोड़ा सा बढ़ रहा है. Therefore again there would be dilution. So this is called as hypervolemic hyponatremia. It is seen in cases of congestive heart failure, cirrhosis or ascites in a patient, and chronic kidney disease. ठीक है, तो जल्दी से एक बार, if total body water and total body salt are both decreased, it is called as hypovolemic hyponatremia. The cause is diarrhea or cerebral salt wasting syndrome. Next, if total body water is increased but total body salt is normal, it is called as euvolemic hyponatremia, and the cause is SIADS, syndrome of inappropriate ADS secretion. Next, if the total body water is also increased and total body salt is also increased, but it is disproportionate rise, it would lead to hypervolemic hyponatremia, and the causes can be CHF, ascites, CAD. जल्दी से ड्रग ऑफ चॉइस बता दो. इसमें क्या दोगे? Here you will give the drug of choice. Diuretics है, those are spironol है. The drug of choice for hypervolemic hyponatremia है. Drug of choice for hypervolemic. Drug of choice for hypervolemic. So ascites का अगर आता है, this was a question. Drug of choice for ascites, answer is spironol. Drug of choice for ascites. Drug of choice for edema, CHF if you don't ask, then answer to do diuretics. Like this. ठीक है, but if ascites or CKD, the better answer to be given is spironolactone. Drug of choice for SIDS. These are drugs known as lactams. tolivaptan, tolvaptan. Okay, these are V2 receptor antagonists. SIDH के drug of choice are SIDH के drug of choice are SIDH के drug of choice are aptans. Okay, diarrhea में IV fluids या OR depending on the CKL. No issues with this. ये table important है कि तुम्हें इसमें भी मिल जाएगा. Okay, moving further. Last part from nephro, उसके बाद break ले लो बड़ी. Break कितने बजे? 6:40. 6:35 पे. ठीक है, चलो देखते हैं. So diuretics की अगर मैं बात करूँ, the first diuretics means the drugs causing loss of diuretics. मैंने natriuretics बोला? नहीं बोला. Natriuretics means loss of sodium. Diuretics mainly cause loss of water. Definitely there can be subsequent loss of sodium, but main action of diuretics is loss of water, right? So the first diuretics, they act on the proximal convoluted tubule. These are called as osmotic diuretics. And which is the osmotic diuretic? Mannitol. The osmotic diuretic is? It is usually used for cerebral edema, but it is absolutely contraindicated in active cerebral hemorrhage. तो ये मैंने active लिखना क्यों था? तो important समझा. Important ये question में खेलते तुम्हारे साथ. Important. Please remember, mannitol is used in cases of cerebral edema, right? And cerebral hemorrhage में क्या होगा? देखो, patient is having subdural hemorrhage, right? There will be raised ICP. Increased intracranial pressure can be there due to again cerebral edema, but that time you definitely give mannitol to the patient because the hemorrhage or the bleeding is not active now. Okay, so if there is an active cerebral hemorrhage, definitely which drug is contraindicated? Because it causes herniation of it. It can decrease the ICPs rapidly and suddenly. That will lead to uncle herniation. Okay, so please remember, mannitol is used in cases of but contraindicated in cases of active cerebral hemorrhage. Next, second drug that you can see, it also acts at the level of PCT. Which is the drug? Carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are drugs like, these are drugs like acetazolamide, brinzolamide, dorzolamide, right? Important. And these carbonic anhydrase inhibitors like acetazolamide, they can also lead to loss of water and sodium from the body. Important. Acetazolamide is the drug of choice. Direct question tha ye. Mountain sickness. Acetazolamide is the drug of choice for? Acetazolamide is the drug of choice for? Acetazolamide is among the first drugs given for angle closure glaucoma. Acetazolamide is among the first drugs given for? Acetazolamide is among the first drugs given for angle closure glaucoma. Along with mannitol, we also give acetazolamide to the patient. No issues with this. Important. Third, carbonic anhydrase inhibitors के बाद the drugs which act at the ascending limb of loop of Henle. These are loop diuretics. Loop diuretics are drugs like furosemide, bumetanide, torsemide. ठीक है? And these are also called as high efficacy or high ceiling diuretics because the strongest diuretics are loop diuretics, and they will inhibit which transporter? Sodium, potassium, 2-chloride synthoter or 2-chloride co-transporter. ठीक है? So loop diuretics inhibit sodium. Loop diuretics inhibit sodium, potassium, 2-chloride transporter. Next, the drugs which act at the level of DCT. These are known as thiazide. Drugs like methiazide, hydrochlorothiazide, chlorothiazide, and these are the drug of choice for hypertension. For maintenance of hypertension, drug of choice are loop diuretics of furosemide is the drug of choice for pulmonary edema or any type of edema for that matter caused by congestive heart failure. ठीक है? So drug of choice for edema are Drug of choice for edema is? Drug of choice for edema is? Drug of choice for hypertension is? Drug of choice for hypertension is? Lastly, I'll discuss this and then I'll talk about these two. Fifth drug, which will act on the collecting tubule. This drug is known as, these drugs are known as potassium sparing diuretics. These drugs are called as, they can be remembered as paste. Okay? P for potassium sparing diuretics, A for amyloride, A for S for T for triamterene, T for and E for eplerenone. E for, out of these spironolactone and eplerenone are aldosterone antagonists. Spironolactone and eplerenone are two aldosterone antagonists are spironolactone and amyloride and triamterene. These are ENaC blockers. Amyloride and triamterene are epithelial sodium channel blockers. Okay? Now, these are potassium sparing diuretics. Means all the other diuretics will lead to loss of potassium. They can cause hypokalemia. But potassium sparing diuretics can lead to retention of potassium, that is hyperkalemia in the patient. Okay? Now talking about thiazides and loop diuretics, the most important side effect that you need to remember. These are contraindicated in patients of diabetes because they cause hyperglycemia. These are contraindicated in patients of gout because they cause hyperuricemia. They are also not given in patients who are obese because they cause hyperlipidemia. So three important side effects of thiazide and loop diuretics. Hyper, second is hyper, and third is hyper. Apart from that, they can also cause electrolyte disturbances. And the electrolyte disturbances seen are hyponatremia, hypokalemia, and hypomagnesemia. Important. Okay? These are common to both thiazides as well as loop diuretics. Now, the one side effect which is only seen with thiazide diuretics, that is electrolyte abnormal. Hyper या hypo? एक easy funda. Loop loses calcium. So please remember, if loop diuretics lose calcium in urine, therefore they will cause hypocalcemia. On the other hand, thiazides retain calcium, therefore they will cause hypercalcemia. Which among the two drugs are contraindicated in case of recurrent renal stones? Please remember which among the two drugs are contraindicated in case of recurrent renal stones? Loop diuretics. So important, please remember, they are causing loss of calcium in the urine. Okay, the calcium is coming to the kidneys, and when calcium comes to the kidneys, that is the time when renal stones are formed. Okay, so therefore there is a high risk of forming renal stones in cases of loop diuretics because they lose the calcium. On the other hand, thiazides retain calcium. They don't let calcium come to the kidneys. The chance of renal stones will be reduced. Okay, no issues with this. So please remember, renal stones में कौन से drugs दे सकते हो? Which drugs are contraindicated? No issues with this. एक break ले लो चलो. Neurology, then we'll start. ठीक है ना? क्या चाह रहे हो? कितने टाइम का? 6 बजे एग्जैक्ट ब्रेक दे दें. 5 मिनट. इस तारीख के फिर से ब्रेक मिलेगा. तो सोच लो फिर अभी ब्रेक लेना है या एक लंबा ब्रेक लेना है. चलो अभी ले लो 6:10 को बैक. ओके, आई विल गिव नेक्स्ट बैक एट 6:30. 20 मिनट पहले फिर से ब्रेक लेना. ठीक है, चाय
कितने बजे तक हो गया कंप्लीट?
तो न्यूरो बड़ा है थोड़ा, देखते हैं कंप्लीट करने की कोशिश करेंगे।
9 बजे तक?
हाँ
9-10 बजे तक?
10 बजे तक तो नहीं जाएगा, 8 बजे तक मैं खींचने की कोशिश कर रहा हूँ।
न्यूरो और इसके बाद बस लास्ट है।
बट न्यूरो में फार्मा बहुत है ना, साइकोटिक्स वगैरह सब कुछ है। अगर नहीं पढ़ा है तो 2-3 बार रिवाइज करो। सही लग रहा है? मुझे लग रहा है कंफ्यूजन हो रहा है बहुत, 3 सब्जेक्ट एक साथ है ना।
मैं तो पीछे वाली चैंटिंग भी देख के आया हूं ना, तो मतलब ऐसा रिकॉर्ड पूरा का पूरा ये फार्मा वाला रिकॉर्ड
बस उसमें इमेज नहीं थे, इमेज के हिसाब से
ये यूट्यूब नहीं है क्या? ये पढ़ लो लास्ट में, ये इनफ है।